All right, good evening, folks, and welcome to the Alaska Eating Disorders Echo. This Echo is jointly provided by AKITA and UAA Center for Human Development Echo Project. Funding for our Eating Disorders Echo has been provided by the Alaska Community Foundation, State of Alaska, and the Alaska Mental Health Trust Authority. My name is Erin, my pronouns are they, them, and I'm a coordinator with the Center for Human Development's Echo Project. So these bi-weekly sessions offer a forum for Alaskan interdisciplinary healthcare professionals to connect with eating disorders experts. This is the first of our 6 sessions running from September through November, and each of our sessions will include a didactic presentation from a subject matter expert followed by a Q&A, as well as a case presentation, which will provide an opportunity for our participants to engage critically and collaboratively with illustrative examples of important and noteworthy topics relating to eating disorders and their treatment. This series has been approved for continuing education credits, and participants can claim 1.5 credit hours per session of this Echo series. In order to claim these credits, you must first attend our live session and then complete an evaluation form, after which you'll be redirected to receive and download confirmation of your continuing education credits. At the end of our session today, a link to that evaluation will be provided in the chat box, so we do invite you to keep an eye out for that. I also encourage folks who are not joining for continuing education credits to also fill out that survey, as it is an opportunity for us to learn how we're doing and how we might be able to improve. All right, let's jump into a few Zoom reminders. If your internet connection does not support audio, you can find a phone number to call in the chat box along with the meeting ID. Closed captions are automatically generated, and those can be turned on by selecting the CC icon at the bottom of your Zoom screen. We do invite you to take a moment to turn on your camera so that we can all get to know each other just a little bit better. It's totally fine if you're not available to turn on your camera. There is no pressure, but it's certainly an opportunity for us to put some faces with names and engage more naturally during the course of our session. We do ask that you keep your microphone muted during our presentations, however, and also when you're not speaking. And you can mute and unmute yourself by selecting the microphone icon on the lower left of your screen, or by entering *6 if you're calling in via phone. Also, you can turn on your camera by selecting the camera icon also on the lower left of your Zoom screen. All right, and finally, whether you've joined in on Echoes before or not, it is important to know that engagement with the group is integral to the all teach, all learn philosophy that underpins our program. And we encourage everyone to ask questions and make comments during our session by utilizing the chat box, or when appropriate, by unmuting yourself and raising your hand, which is a feature of Zoom, and sharing directly with our group. You're also welcome to private chat the session host, that would be myself, or any members of the Hub team that are labeled Hub, if you'd like to share your questions or comments anonymously. And let's see, so final reminder here, we do ask that folks please be mindful when engaging in discussions, and at all times conduct themselves with propriety and respect for the others in the session, especially, as we are discussing sometimes difficult topics. So thank you for that. All right, and to further help build connections and foster participation throughout our Echo, we do like to start each session with introductions. Participants, feel free to share your name, role, and organization in the chat box while I go ahead and introduce our Hub team members and guest presenters. All right, Hub team, when I call on you, if you could also share the same, your name, role, organization, and a little bit about what brings you into this group and the passion behind this endeavor. Starting with Beth, if you would.
Wonderful. Thank you, Erin. My name is Beth Rose. I'm one of the co-founders of the Alaska Eating Disorders Alliance. And our other co-founder, Jenny Loudon, can't be with us tonight, but she'll be joining with us at the next Project Echo. And I just wanted to say a big welcome. I see people are coming from Australia, from the East Coast, and all over Alaska. And it is a delight. I'll be able to do some more introductions soon and share a little bit, but just a delight to see everybody here tonight, and hope that you find that this Alaska Eating Disorders Project ECHO to be really useful for you.
Thanks so much, Beth. Crystal, if you could also introduce yourself with your name and organization.
Hey there, I'm Crystal Cuellar. I use she, her pronouns. I'm one of the adolescent medicine physicians at Seattle Children's. So I do a lot of clinical work on both the outpatient and inpatient settings. Really excited for this opportunity to be part of this Project ECHO. I have a big interest in education and kind of just reaching out to the community to provide some of the learning opportunities that I've been afforded at Seattle Children's. So look forward to working with y'all as part of this project.
Thank you so much. Chris-Ann.
Yes, hi, good evening. I'm Chris-Ann Rice. I am a volunteer with the Alaska Eating Disorder Alliance, and I am a parent of a daughter who is in very strong recovery from anorexia. And I am passionate about this as a parent, and this is absolutely exciting because this was not around before. So this is a wonderful resource. I'm thrilled to be part of it.
We're definitely thrilled to have you, Chris-Ann. Thanks.
Thanks.
And Zena.
Hi there, everyone. And Zena Murari, she, her. I serve on the board of the Alaska Eating Disorder Alliance, and I'm so happy to be here and be part of this. I also teach as an adjunct professor in the Department of Fine Arts for the University of Alaska Anchorage, and as a program officer for the Rasmussen Foundation here in Anchorage.
Excellent. All right, Melissa, if you would.
Hello, my name is Melissa O'Neill. I use she, her pronouns, and I have been a counselor in Anchorage, Alaska. We've recently moved to Anchorage, Kentucky. I'm a certified eating disorder specialist supervisor and still offering supervision services in Alaska. I'm also a counselor educator with Adams State University. Good to see everybody here.
Great to have you, Melissa. Let's see, Keegan.
Hi, good evening. I'm Keegan Carroll. I am a wellness coach at Jammy Health and Wellness here in Juneau, Alaska. I started this journey right when Akita was first starting as a parent supporting a loved one. And I have grown with the Alliance and serve on the board of directors. I'm an eating disorder advocate for parents, and I am an ambassador for the Eating Disorder Coalition.
All right, thanks, Keegan. And Grace.
Hi, everyone. I'm Grace Schumacher. I'm a dietitian in the Anchorage area, also an eating disorders certified specialist, and an occupational therapy student. So I'm on the board of directors with the Alaska Eating Disorders Alliance. Also serve as president for our International Association for Eating Disorders Professionals in Alaska chapter. And I'm also an advocate with the International Federation of Eating Disorders Dietitians. Good to be here.
Fantastic to have you as well, Grace. Let's see, Jessica Setnick.
Hi there, Jessica Setnick here. I am from Dallas, but I am speaking to you right now from Boston. I am an eating disorder dietitian and certified eating disorder specialist, and I will also be the presenter for one of the later sessions.
All right, great to have you, Jessica. And Brooke, if you would.
Hi, my name is Brooke Zarnecki. I am a virtual dietitian right here in Anchorage, Alaska, and I work with individuals with eating disorders and also a specialty in sports nutrition. So we're happy to be here.
All right, thanks so much for our hub team for those introductions. And a final note before I hand things over to Beth to share a little bit about the Alaska Eating Disorders Alliance and the mission that's driving this ECHO before they then turn it over to Dr. Tantillo. So the opinions of our hub team members and presenters are their own and do not necessarily represent those of AKITA, UAA, or any ECHO sponsors. Additionally, we do remind folks that Project ECHO is not HIPAA compliant. Therefore, we ask that no protected health information is shared or displayed at any time. So thank you to everyone for following those guidelines. All right, over to you, Beth.
Thank you, Erin. My name is Beth Rose. Again, my pronouns are she, her. And as I said, I'm one of the co-founders of Alaska Eating Disorders Alliance. And I'm thrilled to welcome more than 200 people here tonight to this Project ECHO, our inaugural Project ECHO. And our goal for the Alaska Eating Disorders Project ECHO is that together we can grow capacity within our local healthcare systems to better understand, diagnose, and treat eating disorders. And that is particularly important in Alaska, since we are a remote state with limited healthcare resources related to eating disorders. So just thrilled that there's a lot of you who are taking an interest in this. And during our time together, we will be learning from the ECHO presentations and also gaining knowledge through our discussions with each other. And this is an open space where all voices and bodies are welcome. We encourage you to be mindful and seek ways to use inclusive, non-stigmatizing language. And I'm going to provide a broad outline of this evening's agenda. We're going to begin with a didactic presentation provided by Dr. Mary Tantillo, titled A New Framework for Understanding Eating Disorders, Diseases of Disconnection. And this will be followed by a Q&A moderated by our hub team of subject matter experts. Then we will hear a case presentation by Sitka-based counselor Melissa Marconi Wenzel. And then we'll have conversation about the case presentation. And now I'm pleased to introduce tonight's presenter, Dr. Mary Tantillo. And she's got a lot of accolades, so this is going to be a very short introduction. I won't cover everything that you have done, Mary. But Dr. Tantillo is a well-known expert in the field of eating disorders with over 30 years of experience working in both the clinical and research settings. Dr. Tantillo is a fellow and past board member of the International Academy of Eating Disorders. She has a doctorate in nursing and serves as a professor at the University of Rochester in both the School of Nursing and the School of Medicine and Dentistry. She's the director of the Western New York Comprehensive Care Center for Eating Disorders, which notably launched the world's first eating disorder-related Project ECHO and has been running for several years strong now. And AKITA's other co-founder, Jenny Loudon, and I have learned a lot from Dr. Tantillo as we were developing this Project ECHO. So we're grateful for your tutelage, your expertise, and your help with this. And so please help me welcome tonight's guest presenter, Dr. Mary Tantillo, and I'm going to turn it over to you.
Thank you, Beth. First of all, can I just say you are all incredible. There's like 223 people participating in this. I'm going to go back to Rochester and give a full report on this. So thank you for having me. I am going to share my screen and hopefully things will come out right when I do that. Can you guys see that? How about that? Is that okay?
Looks excellent.
Okay, great. So what I promised Beth and folks is that I would start out with some myth busting. Before we get there, these are the kind of things that I hope you guys will come away with by the time we're done talking. So what I'm going to talk a little bit about is a relational motivational stance to take with eating disorders, and I'm going to relationally reframe eating disorders for you so you'll understand why that stance is so important. Hopefully you'll take away this idea that there are internal and interpersonal disconnections that are created by eating disorders, and that there's definite strategies we can use to promote mutuality, to name and repair disconnections, and to increase motivation for recovery. So here's our quiz part. True or false? I can't see the top of my screen, I don't know why, but eating disorders affect people of all ages, races, ethnicities, body shapes, weight, sexual orientations, and socioeconomic statuses. You guys can unmute. True or false?
True.
True.
Excellent. Very good.
True.
Yep.
True.
And fortunately, there's a lot of myths that would just say that white upper class girls get eating disorders. Not true. How about families are not to blame and are often the patients and providers' best allies in treatment? True or false?
True.
Yes.
True.
Absolutely. It just took psychiatry a number of decades to figure this out, that they had the best resource right in front of them the whole time, right? True or false? Environment is a reason for the development of an eating disorder. This is tricky. True or false?
True.
So it's
I'd say both.
It's half true. So it's gene by environment interaction. So people have vulnerable genes. Those genes can get turned on by environmental stressors that start to produce proteins, and then you start seeing symptoms. So it's really both. But 50 to 80% of why someone goes on to an eating disorder has to do with genes. The rest has to do with environment. So people with eating disorders are preoccupied with vanity, attention seeking, and want to control other people. True or false?
False.
Absolutely. This is a myth, which is a very painful thing. And the control we talk about that patients want is not control of others so much as it is just feeling like they're in a free fall. And who wants to feel like that all day, right? Nobody wants to have an eating disorder. Eating disorders have the highest mortality rate of any psychiatric disorder. True or false?
True.
False.
True.
So the person who said false, if you're thinking that opioid dependence actually is ahead of this, you're right. That's the only condition that trumps mortality rate in terms of eating disorders. But other than that, eating disorders sadly have the highest mortality rate of any other psychiatric disorder. You can tell someone has an eating disorder by their appearance or lab values.
False.
Very good. Very good. Because remember, people can look like they're okay, but be very sick with an eating disorder. And lab values are measuring the amount of electrolytes that are in our blood, not in the cells of the tissue. So sadly, I know a case of a young lady who had restricted a lot. The campus didn't know she was sick with bulimia. She didn't eat well, she overexercised, and she probably had just enough potassium in her blood to make it look like she had a low normal value of potassium. But she binged and she purged 10 times before she went to bed that night, and she never woke up. So lab values are one thing, but you need a full physical exam, a full mental health evaluation, lab values, vital signs, and a nutritional assessment all together to really show that someone is in trouble or not. Women are at greater risk for osteoporosis than men with anorexia nervosa. True or false?
True.
I'd say true.
Well, it's false because there are a lot of men who can end up with orthopedic problems. Because remember, if we're not taking in enough fat to make hormones, we're not making testosterone or estrogen in the way that we should. And either way, males or females their bone health can be affected. So it's important to remember that. Malnutrition occurs exclusively in patients of low weight engaging in disordered eating behaviors. True or false?
False.
Very good. Very good. You can be malnourished at a number of weights, not just at a low weight, right? Very good. Wanting to exercise and grow muscles is always a sign of physical health. True or false?
False.
Excellent. Of course, it can be an eating disorder. It can be because remember, men are more apt to not pay attention to the number on the scale as much as women, but they do want to bulk up and sometimes want to bulk up and be slender at the same time. So it's false. Eating disorders carry an increased risk for suicide. True or false?
True.
Yep, absolutely. Because anorexia nervosa, for example, 20% of the deaths are due to suicide. True or false? Unless someone is ready to let go of their eating disorder, there's nothing I can do to help until they're ready. True or false?
False.
Very good. False. Remember, motivation waxes and wanes. So to continue to keep the door open and encourage patients is very important because you never know when they're going to turn that corner. Full recovery from an eating disorder is possible. True or false?
True.
Absolutely. Absolutely true.
True.
Absolutely. Eating disorders are a choice. True or false?
False.
Absolutely. They're not a choice. This is Meredith's
False.
parent. If you want to go to her YouTube and take a look at what she did, she calls it End the Silence, and eating disorders are not a choice. I often bring this piece to legislator offices because I'm trying to educate them on how eating disorders are not a choice. So tonight, what I want to talk about is a relational motivational approach to eating disorders. This is based on 35 years of listening to the lived experience of patients and families who taught me that talking relationally about eating disorders makes more sense. And so a relational motivational approach to healing makes a ton of sense once you relationally reframe eating disorders as diseases of disconnection. So this approach we'll talk about is has a thread of stages of change theory as part of it. It has threads of motivational interviewing, which is, how to be with patients and families when they're trying to make changes and move from stage to stage and resolve ambivalence and try to solicit more change talk and try to create discrepancy between life values and goals and the impact of the illness. But what I'll probably focus on the most is relational cultural theory, which is at the heart of this approach, because it's really super concerned with identifying and repairing internal and interpersonal disconnections that characterize eating disorders. And the goal then becomes connection with self, connection with others. And we do that through developing perceived mutuality, which I'll talk more about. So giving patients emotional and relational tools to experience perceived mutuality with their family and their professional team members is super important. So if we're going to relationally reframe eating disorders, what do I mean by that they're diseases of disconnection? There are internal and interpersonal disconnections that are very much characterize eating disorders. These processes of disconnection might have actually been in effect even before a person is diagnosed, but we need more longitudinal research to prove that. But be that as it may, once someone is starved enough, distracted enough, electrolyte imbalanced enough, fatigued enough, malnourished enough, they are definitely at a place where they're more disconnected from their authentic feelings, thoughts, and needs, which is the goal of the eating disorder. And they're also disconnected from their bodily states. It's very hard for them to judge their hunger and their fullness, for example. And that's what the eating disorder wants. And so think about it. If a patient is in that much trouble themselves, it's going to be hard enough for them to figure out what's going on with themselves, let alone communicating that clearly to people who love them. And as we all know, eating disorders are very secretive. And some patients, a hallmark of anorexia nervosa is anosognosia. Patients sometimes don't even think they have a problem, right? Or they're very ambivalent and they're frightened of giving up the illness because they don't have a good sense of themselves, who they'll be after they give up that illness. So there's definitely internal disconnections that can happen. And then there's disconnections that happen between the patient and the family, because once the family finally does find out something is going on, they're really worried about what to say. They're worried about saying the wrong thing. There can be lots of tension or silence or isolation that goes on between patients and family members. The eating disorder, of course, loves that because it wants to stay right alongside the patient and get rid of the rest of us. Eating disorders can also create tension between the family of origin and extended family and friends, because when you bring your loved one who's struggling to other family and friends, people try to say what they think are helpful things, but aren't so helpful. Like, why don't you get her to eat, or why don't you stop him from throwing up? And trust me, if that's all it took, we wouldn't even be on the call today. And so families start isolating more, and then less positive energy is coming in for change and recovery and healing. The eating disorder loves to create disconnections between the patient family and the professional treatment team. It gets us arguing about meal planning, gets us arguing about weight ranges and activity levels. And we know that the eating disorder is on the scene trying to divide and conquer us when we're having very polarized all or nothing black and white thinking. And the same kind of thinking can actually happen among the professional treatment team members themselves. If you talk to people who treat patients and families and you ask them, do any of those disconnections that happen at home with the patient happen at the treatment center? The answer is yes. because the illness always is looking for ways to pit us against each other and to use splitting as one form of making that happen. So disconnections can start internal to the patient and then radiate out all the way to the team, or if the team's not getting along well, it's going to impact and can create disconnections with the family and the patient. I wanted to give you some examples of what I meant by intrapersonal processes of disconnection. These are the ones that are characterizing the patient. They're internal, they're psychological and biological. So for example, alexithymia certainly promotes disconnection because we have trouble identifying and describing the feelings that we have. Poor interoceptive awareness, difficulty accurately sensing our internal bodily states. There's even research to support a disconnection in the insula. Brian Lask and colleagues have written about this. And that's a problem because the insula takes external sensory information and then synthesizes it with internal information from our vital organs, for example. And you can see how much trouble that would cause a patient in terms of information processing when that's going on. They're not reading facial expression properly. They're not seeing properly what's in the mirror or seeing a body part accurately when they're looking down on their leg, for example. There's weak central coherence. They have strengths in terms of focusing on detail, but may have trouble looking at the big picture. Lots of cognitive rigidity, anxiety, harm avoidance, and then starvation itself has a numbing effect, which disconnects the patient from themselves. There's another set of internal processes of disconnection, which I've labeled interpersonal, because they still characterize the patient, but they can create interpersonal difficulties. So when the patient avoids conflict, isolates, avoids intense emotions, silences their own needs, minimizes their own needs and feelings, compares themselves with others and always feels less than. These are all processes of disconnection because they make the patient, again, disconnect from themselves, but then can also create disconnections with others, because think about it, the interplay of these internal processes, along with interactions with loved ones who are also dealing with the caregiving burden, which is as high as taking care of somebody with a psychotic disorder, and family and friends who are also psychologically distressed because of the illness, can cause interpersonal disconnections with family and loved ones. This is a quote from an adult with AN about the an intrapersonal process of disconnection. I'll let you guys read this for a second. I think this is important because she's saying it's not just about control. Everybody assumes eating disorders are about control. Yes, they can be about control, but she's pointing out that it's the disconnect. It's not having to feel the intense emotions that she was frightened of feeling that made the eating disorder attractive for her. That was the purpose that it was serving. So as I said, those other internal disconnections can interplay with interactions with family and friends. And then we get into these interpersonal disconnections that can happen with close others. And you know that they're happening when people are focusing on the detail at the expense of the big picture. Family and friends may get emotionally overprotective and not allow for increased autonomy. Well, of course, because they get frightened of letting people get away from them that they love. They are afraid they're going to get into more trouble. There can be an avoidance of conflict. People end up walking on eggshells. There can be more criticism and validation, inability to compromise, shaming, blaming. Again, this is the impact of the eating disorder because of the burden it's placing on the patient and on the family. This is an example from a mom who's talking about the disconnections that went on in her home because of her young adult who had anorexia nervosa. I'll let you read through this for a second. So what the mom is pointing out is that instead of blaming each other, let's all focus on the eating disorder and look at all the disconnections it's creating and then name them and try to repair them so we can have growth that can come out of that disconnection. I'm crediting my son with these circles because he says, Mom, you got to do a graphic. You can't just keep talking. So here's a typical disconnection, right? The two people are totally separate, isolated, miscommunication, misunderstanding, tension. The point is there's isolation. And isolation, they've done the research, as a risk factor for mortality and morbidity is just as bad as smoking almost a full pack of cigarettes. So when we give up isolation, it's like giving up 3/4 of a pack of cigarettes. So this is not a good situation to be in when you're a patient and a family member. This is another way of thinking about disconnections, which some of us might call us enmeshed. I don't use those words typically, but it's like it looks like an Uber connection, right? But it's not. It really ends up being a disconnection because people in situations like this are walking on eggshells. They're not feeling like they can be authentic with each other. They can't talk about different thoughts or feelings or needs because they're afraid they're going to lose the last shred of connection they have with their loved one. And so there is no space for each person's uniqueness and difference. So it's kind of pseudo-mutual, right? So that's not good either. And the eating disorder loves to create this kind of disconnection as well. So disconnections in and of themselves, I mean, they're painful, but they're not necessarily bad. They can actually end up with growth if we are repairing them. But the damaging ones are the ones that continue without repair. And those are the ones that can lead to things like eating disorders or substance use and lots of other physical or mental health problems. So the goal is to validate. But when we don't validate, when we lack empathy, when there's an erosion of perceived mutuality, then there's a lack of healing and growth and recovery. When we have lots of disconnections, we can start developing very negative relational images and meanings of ourselves. This is just one example that a patient shared with a group, that when she tried to convey her experience, no one seemed to be listening. She was talking about her parents when she was giving this example. It could have been anybody, just happened to be parents in this. And then she made sense out of it by saying that she was the unworthy one, and if she didn't exist, her family would be better off. You can imagine the pain she felt walking around with those meanings and images. This was all unconscious initially till she was doing her group work. And then, of course, eating disorders can take care of those feelings and curb them or mute them or silence them, right, by binging, purging, restricting. The interesting part about this case was that the mom had 25 years of untreated depression. The patient was the daughter. And you can see how painful that would be. And the dad was a traveling salesman. So you can, they loved each other for sure, but because of the pain that was going on with mental health conditions untreated at home, the patient ended up blaming herself. So it's not anyone's fault, but the eating disorder, she was more vulnerable to the eating disorder because it solved the pain around that situation. You're going to see some animals float in here. This is Janet Treasure's animals. Lots of negative relational messages that we have over and over again can get us feeling and acting like these animals in the boxes below. It's very hard to feel a sense of worthlessness and the negative images and the meanings that go on when we keep having disconnections that are not named and repaired. And so that's why the eating disorder becomes so attractive, right? And so it can perpetuate itself over time. We can become avoidant and not talk to each other, bury our heads in the sand. We can become overprotective, keeping the patient too close to us and not giving them choice and autonomy when it's time to do that. We can get aggressive with each other. We can do that on the team as well, not just between patients and families, but with each other on the professional team. If we're not careful, we can all develop these relational images and messages ourselves. We can get over emotional like a jellyfish and dysregulated, or we can become critical with each other like a terrier. So the goal is to be more like dolphins and St. Bernards, because they swim right alongside each other. They don't go too far up, they don't go too far back. And when anybody gets off track, they lovingly, gently nudge each other back on track, whether that's the team we're talking about or patients and families, how we teach them to do that. Not like rhinoceroses going after each other. So the name of the game here is perceived mutuality, which is really mutual empathy and empowerment, which can protect us against disconnection and help us repair them when they happen. In terms of what perceived mutuality is, it's that back and forth flow of thoughts, feelings, and activity. And a big piece of this is sensing, knowing that we influence others and letting others influence us. So for an example, I'm sitting in a multifamily group looking across the way and I see a dad and daughter getting into it. What I want to do is model for them perceived mutuality, which is letting them know that they influenced me, right? And so I would say to them, you know, I'm watching what's happening over there. I'm feeling very sad and frustrated for the two of you. I'm not sure if that's what you guys are feeling. I'm really curious about what it is you're feeling, but is it the same or different from what I'm experiencing while I'm watching what's happening? And then that lets them know that they've affected me, right? And then they have to bring that into themselves and practice self-empathy. They say to themselves, gee, do I feel the same way as Mary or a different way? Then they have to bring that back out into the interpersonal field and say, yes, I do, or no, I don't. I also feel this. So it gets them practicing difference as well, because difference and connection is what we want. and without a fear of reprisal or losing a connection with someone because you said something different, a different thought, feeling, need. And so that's what I mean by sensing that we influence others and letting others influence us. That's important because it helps us be emotionally vulnerable and more open to feedback, helps us to be responsive to the other person and to ourselves at the same time, right? Connecting with self and others. And it means, perceived mutuality means we're taking in the wholeness of the other person, not just what makes us similar, but also we take in the differences of each other, and that we let them complement each other and strengthen the relationship instead of letting the eating disorder use our differences against us and create disconnection. You know that you're in a mutual relationship when these 5 good things are happening, and you can see our St. Bernard and dolphins are a big part of those 5 good things. So this is what we're trying to encourage in patients and families and on our treatment teams. So this is the goal, this Venn diagram, which the eating disorder hates this diagram because we cultivate each person's uniqueness in the relationship as well as the integrity of the we. So there's space for each person as well as a space for difference, but in relationship. And this is what we're teaching our team members and teaching patients and families all the time. A lot of the work that's done in a relational motivational approach, the heart of it is perceived mutuality, and naming this, helping them name disconnection and points of tension. That could be around the meal plan, that could be around visiting friends who you're worried have a bad influence on the person that you love. Those points of tension can be lots of different things. But the point is naming them and helping look at both sides and doing problem solving around that. We don't have a lot of time tonight, so I'm hoping that you guys know about stages of change, but these are the stages that patients go through no matter what they're trying to change. And so in a relational motivational approach, it becomes very important to teach these stages to patients and families so they know in pre-contemplation, the patient's going to, of course, be in denial, in contemplation, ambivalent. Preparation is next. Behavioral change and action is next. Maintenance is being without symptoms for 6 months or more. And then termination is being so well recovered that you don't even have a thought of an eating disorder. And that doesn't mean everybody, because some people are just in lifelong maintenance. It's not a right or wrong thing. Everyone's recovery is different. There are some motivational principles that are important along with the mutuality principles. And so I'll just briefly go through them. So expressing empathy becomes super important. It seems really simple on a slide, but is challenging in real life when we're tired, right? And feeling burdened, all of us, by the illness, including the patient and family. But validating the pros or the purposes or the meanings of the illness is very important to patients. When a patient feels like you get why there's pros to the illness and the purposes that it serves, they're more willing to do scary things, like try new things that we ask them to do. Developing discrepancy is very important, which is helping the patient consider whether the eating disorder is helping or hindering their attainment of their life goals and living out their life values. So if somebody wants to go to school 800 miles away from their parents, or for example, but is still binging and purging through the evening, it's important not to lecture, but to help the patient remember what it is they want to do, which is go away to school to have a sense of autonomy and independence, and say that we want to support that. And at the same time, ask them, is it helping them get towards those goals, the binging and purging, or not? And if their values are transparency and honesty and integrity, is the illness helping you live out those values or not? Avoiding argumentation is very important because when there's a fight with the eating disorder, guess who usually wins? So instead of arguing, it's better to develop discrepancy, like I just talked about, and use empathy and promote the patient's self-worth and confidence. So again, being a St. Bernard or a dolphin instead of a rhinoceros or an ostrich or a jellyfish or a terrier. Rolling with resistance is very important. It's going straight at a problem full speed is not necessarily going to work when you're working with a patient with an eating disorder. You probably have to come alongside the patient or come in through the back door. And use validation and empathy. So noting how challenging something is for the patient while also offering up concern. It's like, it's a both and kind of thing. Like think about a sailboat. A sailboat, when it comes back into the shore, is going dialectic, side to side. So when you're talking to a patient, for example, the college patient I was just talking about, it's important to acknowledge what they think is important. Like, I hear how important it is for you to go to school 800 miles away from your parents so that you can feel a sense of autonomy and independence. It makes complete sense as a young adult. And at the same time, notice I didn't say but or however, because that negates everything that's said up to that point if you do that. You say in addition or also or at the same time, you're telling me that you're still struggling with binging and purging through the night. Let's talk about what we can do to help you attain your goal and not let the eating disorder take advantage of you. So it's a both and. And another analogy I often use is if you're in a large body of water and there's a riptide, the worst thing you can do is swim straight toward the shore. You have to tack back and forth. Supporting self-efficacy is also important because patients need to feel a sense of confidence in their ability to care for themselves. And so anything we can do to promote self-efficacy and autonomy and choice, even if the choices seem slim. In the beginning of recovery, you don't want to turn to a patient and say, okay, choose your entire meal plan. But we teach the families to say things like, here are 3 things that are possible. Which of these things do you want today? Right? And as patients get better, they can have more choices in what they're choosing about, whether that's meals or other activities. Because of the time element today, I'm just going to go past these slides because we've talked about this. A lot of the work that happens in this approach is around this triangle. Identifying the connections between patients' relationship with food and the illness, the relationship with self, and the relationship with others. You can start at any point on that triangle and work back towards the other 2. So for example, if a patient's having an argument with a partner, you can talk about from both of their perspectives, what they were feeling, what they were thinking, trying to get at that mutuality piece, how they affect each other. And you can help the patient clarify the feelings they were having, to connect with themselves while they're having this discussion. Like, they often don't know what they're feeling. So that means they get a feeling list, or they get help with biological and behavioral cues. You help them develop an ability to process information so they can connect with themselves, or they're also trying to connect with the other person. And then you can back into the third point there, which is, how did the eating disorder capitalize on this disconnection you were having with your partner and these feelings that you were having a tough time letting yourself experience? How did it capitalize on that? What happened next? And then over time, getting them to back up to the earliest cue that lets them know they're going in that direction. I'm looking at the time. I'm going to just talk a little bit about healthcare provider approach, which is, again, validation, validation, validation. Because the eating disorder is all about shame or secrecy, validation is like Neosporin. You can never give the patient enough validation. And normalizing what's going on in some way helps pave the way for more disclosure. Being direct and specific with questions is important because the eating disorder is also trying to tell the patient not to give you the truth. Well, the healthy part of the patient wants to tell you what's happening. So starting out with open-ended questions is important, but you have to be specific, like, walk me through a day of eating. How much, you said you had cereal and milk. How much cereal? How much milk? You said that you do exercise. Tell me how many minutes a day that you're exercising. What kind of exercise? Never assume, because the eating disorder creates lots of cognitive distortions and reasoning errors, lots of all or nothing thinking. The patient could have a negative mental filter, walk away with just one thing you said, which wasn't even critical, but gets turned into a criticism, and they didn't walk away with any of the positives that you were offering that day. Being genuine and real, what I mean by that is not to be opaque and distant, because there's lots of disconnections you're reaching across. There's physical ones, there's psychological ones, there's relational ones. And so being genuine and more active in the room is important, kind of like how we are with adolescents. That's how I would be with any adult or any adolescent with an eating disorder, because it helps with that self-disclosure when you're like that. They will fill in the blank with the wrong thing if we're too opaque and far away in our relationship. It just creates another opportunity for disconnection. Naming things when patients can't, when they're too scared, whether that's a conflict or a point of tension or a disconnection, is important. Using warmth and humor, being consistent and persuasive, and using informal and formal education, and staying together on the team approach is super important. I'm going to do a time check with Beth. Do I have 5 more minutes or no?
I think you do have 5 minutes. Yes, we may keep have the questions be a little bit shorter, or perhaps even after the case presentation, but please take another 5 minutes.
Okay. There's a ton, I'm going to let you guys go through these slides. There's a ton of different therapist strategies to increase motivation and mutuality. So I'm going to let you look at those on your own. But what I want to do is go to the team slides, because there's a lot of you on tonight. Eating disorders are notorious for splitting, which means the patient will tell one of the providers something and tell another provider something else. This is a coping strategy. And it's actually a coping strategy we use when we're little, right? Or when we're super stressed or traumatized. So it's not like the patient woke up and thought, well, today I'm going to tell Mary this, and I'm going to tell Dr. Kripke this. It doesn't usually happen that way. But the point is, it's the eating disorder, not the patient. And so it's important not to get, angry with the patient and blaming. But what I used to do with Dr. Kripke, who's in adolescent medicine, is a patient would come to me and say, Dr. Kripke said X, Y, and Z, and I'm not working with him anymore. And I would say, you know what? Dr. Kripke would be really interested in the fact that you're very upset with him. Why don't we call him right now? So it would stop the splitting, right? That's how we have to interact with each other. Don't make changes in the treatment plan that everybody agrees with because the patient says that they're unhappy. You want to move as a unified front. So if the patient says they're unhappy with something, you can tell them, let's go back to the team and I'll let them know what's going on and I'll get back to you. But the eating disorder loves to trap us in the moment and wants us to change something without discussing the change with the rest of the team. Don't assume therapy is failing if the patient complains about the therapist. I just gave you an example of what happened with Dr. Kripke. It's the eating disorder, probably trying to get away from the other person that's onto it, right? So don't assume it's failing if the patient says it. You want to check that out with your colleague, what's going on, and name the disconnection with your colleague and see if that's what's really happening or not. More communication is better than less. Having scheduled calls, not just when bad things are happening, but have scheduled calls with your colleagues intermittently, so you can celebrate things too, not just when things are going wrong. Using case review like you guys are doing tonight to look at challenges and strategies. Discussing the implications of the treatment plan for discharge, starting at admission if you're admitting patients. Being clear about what the community supports are for the patient when they're discharged. And again, obtaining outpatient visit appointment times during transitions. Clarifying the roles everybody plays. This is also very important with schools. What's the nurse going to do? What's the counselor going to do at school? What's the primary care physician or nurse practitioner going to do? What's the therapist going to do, right? Having a realistic discharge plan for school personnel is super important, and including mealtime assistance, where lots of splitting can happen. The eating disorder loves to take advantage of that. And again, setting up check-in times with patient and family. So this is your motto, you guys. When the eating disorder is trying to take advantage of you and getting you to change something without talking to the rest of your team, this is your mantra. So I'm going to stop there and stop sharing the screen. Great. I know that was a lot in a short period of time.
I want to thank you, Dr. Tantillo. This is a lot, and I'm glad that you covered a lot. And I'm also glad that your slides and your presentation will be available for people to review again, because there is so much information there. We actually have probably about 10 minutes for some questions. So I'd like to open it up and see what questions folks may have for Dr. Tantillo. And you can ask, you can unmute yourself and ask. You can ask in chat. So let's go ahead and open this up and see what questions or comments you might have.
We do have a large group here, so I'll go ahead and invite folks to use the raise hand feature rather than just coming off of mute directly. Thanks.
And if you can introduce yourself also when you ask a question, that would be really helpful.
Hub team, while we wait for folks to enter in questions on, in the chat box or come off of mute, raise their hand, etc. Any thoughts that have popped up for you about Dr. Tantillo's presentation?
Hey, this is Crystal Cuellar. I'll pipe in while we're gathering some questions here. I was just thinking in terms of disconnect, we're seeing so many of these like long-term effects of COVID and that initial isolation that people were feeling. Everybody was disconnected. So I'm wondering if you could speak a little bit about that impact and kind of that, and how that overlapped with some of the disconnection that we naturally see with eating disorders anyway.
I totally agree. I think it's just made it more severe, right? We've actually called that out in session. Like that in and of itself has created so much isolation. And the eating disorder, as you can imagine, has taken full advantage of all of this. So that, you know, people who were actually doing pretty good in their recovery were having lapses and relapses. There was the onset of illness. So we've actually called that out, like in multifamily group or in relational group that I run that too, or in individual sessions. We've called it out on its own and looked at how the eating disorders tried to capitalize on that, which is helpful for family members and friends to understand, because you know, it's hard enough to understand an eating disorder anyway, but then to understand how COVID has accelerated things, I think took everybody by surprise. Like, for example, people who were doing pretty well in recovery, then they weren't doing well. I think that was surprising to some family members. So being able to make what is implicit explicit is a big piece of this. So yeah, I totally agree, Crystal. It's made it that much more difficult. And we talk about the damaging effects of isolation. Like I said, when you give up isolation and you connect, you're giving up almost a pack of cigarettes. It's that strong of a risk factor for morbidity and mortality.
I'm going to go ahead and ask, there's some questions in the chat, and we also have some folks with their hands raised. A couple of questions came in the chat first, so I'm going to just go to those. And we have a question about, I'm sorry, let me go ahead and get back to this. One of the questions was, do you often see picky eating as eventually becoming an eating disorder, or people with SPD?
Okay, let me go back. So what was the last part of it? SPD?
Or people with SPD?
I'm gonna need help with that. It's late, you guys. I'm trying to remember what the
Probably it's sensory processing disorder.
Oh, okay. Picky eaters do not always go on to an eating disorder or to ARFID, but some do. I guess I'd want to know a family history. So yes and no. I don't like to pathologize things immediately with children, but as a lot of you may know, if you know anything about ARFID, for example, if it's going down the road of increasing disinterest with food, like to the point of nutritional problems or psychosocial impairment, that's a problem. The other road into ARFID is something traumatic happening when you ate and you threw up or you choked, and you want to like avoid eating foods that might lead you down that road again. So if those kinds of things, or textures, right? Sensory problems, I think that's what the person was kind of alluding to, textures or smells. If these things are causing psychosocial impairment and nutritional deficiencies and weight loss, then it's something to really pay attention to. But not every picky eater is gonna become someone with ARFID or an eating disorder, but it's important to pay attention to without pathologizing it immediately.
So many questions. I'm going to actually take some of the folks who do have their hands raised. I think that Neil Prakash was one of the first.
Hi, I was wondering if you've ever seen an eating disorder in the form of comparison to siblings, where one girl is comparing herself to another girl, you know, or one is older and developing and wants to stay appearing young like a younger sibling.
Yep. See, that the part of having an eating disorder is body checking, right? And unfortunately, that body checking and comparison can go on not only with friends, but with your own family members. We've had twins, which you can imagine what that's like, comparing each other, where one twin had an eating disorder already, the other one didn't. But yeah, we have seen that, and that would be a point of tension, right? And it can create all kinds of disconnection. And then, I mean, and I know lots of you probably already know this, but I always say to the patients, something to think about is when they say, well, I'm fat, I say to them, okay, so what does fat mean? Fat means unlovable, fat means unappealing, fat means, so I try to help them understand, to use it as a metaphor for where else they might feel like that in their lives. So in a situation like that, I would want to try to get at what is the one sister feeling about the other sister. They're gonna talk with her about their body, right, first, but you're gonna back into that by saying, what's the meanings attached, what are the feelings you have, and in what other areas do you feel like that with your sister? So yes, we've definitely seen that, the competitiveness too.
So when one sister twin developed the eating disorder, does the other one eventually develop it too? Because
if they're identical twins and one gets the illness and one doesn't, it's not what's shared that's causing that, it's what's not shared. So Kelly Klump and her group have done a lot of research on this. So it doesn't necessarily mean the other one will, but although identical twins are at higher risk for both of them having it because they're sharing the same genes, right? But sometimes one does and one doesn't, and it's what's not shared. So for example, maybe one twin had a certain set of friends that were kind of unsavory, that didn't help in some way, whereas the other twin didn't have that set of friends. So it's what's not shared that makes a difference.
Thank you.
Good question.
Okay, another question here with the piggyback on this one too, and it says, can you review certain tactics or interventions to distract overeating? And someone else said, can you also talk about how the strategies might pertain to, the comment was obesity or overeating, but perhaps that's more on binge eating. So are there different tactics and different ways of providing support for someone experiencing more restrictive eating and having difficulty at meal times versus somebody who may be more in the binge eating spectrum?
So I'm thinking two things. I use metaphors a lot. So I can name off a lot of, if I had patients with me on the call right now and I said to them, what distracting things can you do? They make a long list: changing the environment, journaling, drawing, music, some kind of creative art expression. There's lots of things to try to make the brain go in an opposite direction, right? At the same time, what I'm thinking is, if someone's eating, it's meeting an emotional need. So again, trying to get at what they're feeling before they start is as early as possible. The first clue, the first cue that someone's going to go down that route. It could be a variety of things. It could be the person is sad, the person is angry, the person is lonely, the person is bored. What we have to get at is, what is the emotional need that the eating is meeting, right? And obesity is not an eating disorder, right? But you can have obesity and binge eating disorder together, right? Or you could have binge eating but not have obesity, right? So I would want to get at what emotional need it's serving for the person. And that just takes time, because it's not just about food. It's about other areas in the person's life. And the illness, the eating disorder, is capitalizing on this piece of vulnerability the person's experiencing. So yes, there's all kinds of distractions, including journaling and art and other creative expression and changing the environment. Pets, I can think about a number of things, but in the end, it's also helping the person understand what they're feeling before they're putting the food in their mouth, because it's serving some purpose.
You know, and I think we're just about at time, and I know there's other questions. I'm wondering if, with folks who have their hands up, Nimisha and Gail, if you can put your questions in the chat, and that way we can circle back and hopefully get to them if there's time after the case presentation and discussion. And Mary, you've started so much good discussion here. We could spend the entire time on this, and so we'll just we'll put a pause on this for now, and hopefully we'll have a little time to return. So please do put your questions in chat. And I am going to move on to the case presentation. And so please know that all ECHO cases have been de-identified and that no protected health information will be shared at any time. The case presentation will follow a basic format. First, our presenter will share a case and offer a question for assistance. So as asking for your help, and I think with a number of folks, it might be helpful using the chat function with this as well. But asking for a question of assistance from all of you who are a group of learners. If you do have clarifying questions about the case, there will be an opportunity to ask those questions after the presentation. So listen to the presentation, and then you can certainly ask clarifying questions. And then finally, our group of learners, and that's all of you, and the hub team experts will have an opportunity to offer suggestions or recommendations, and these will be documented and submitted to the presenter for reference. So today's case presentation is by Melissa Marconi Wenzel, and Melissa has a master's degree in clinical mental health counseling from the University of Alaska Fairbanks, and she works in a clinical practice in Sitka, Alaska. Her broad focus area is trauma, and within that area, she sees a number of patients with eating disorders and maladaptive eating issues. So I'm going to turn it over to you, Melissa.
Thank you. Erin, I don't suppose you might be able to share my slides. Oh, thank you. That's wonderful. Well, I'm so excited, everyone, and I'm really looking forward to hearing your perspectives on this case. So this is really a semi-fictionalized case. So I've synthesized several client experiences that I think they highlight key themes related to access of care and impacts to family system functioning associated with eating disorders. So I'll go into it. The client is a non-white cisgender adolescent male from rural Alaska with anorexia nervosa, restricting type, co-occurring depression, intermittent suicidal ideation, that's been a more recent development, and likely undiagnosed ASD level 1. The client has 2 biological parents, they're married, and 1 younger sibling. The client is currently in an inpatient treatment facility for eating disorders in the lower 48, and the clinician is serving in the capacity of providing family system counseling at this time to the parents and the sibling, and working with the inpatient treatment team to develop a continuity of care plan when that becomes appropriate. Upon review of medical records and clinical interviews with the client and his parents, it's clear that disordered eating behaviors and thought patterns were evident as early as middle childhood. So this includes increasing preoccupation with diet and exercise, more body checking, restrictive eating, increasing avoidance of really intense emotions, lots more self-judgment, and increasing social isolation, both internal and external to the family system. So the parents, they sought medical advice periodically, but the signs and symptoms of this emerging eating disorder, they weren't really recognized by providers. And the parents didn't have any education in eating disorders either, as most of us don't. The eating disorder fully emerged about a year ago. The parents struggled to access medical and mental health providers with clinical knowledge of eating disorders. Then they ultimately traveled hundreds of miles from their home community to locate a provider who was able to provide a diagnosis and referrals. And by the time this occurred, they had been trying to manage the client's now very acute condition at home on their own for about 6 months. Once the diagnosis was made and a treatment plan was developed, the client then decompensated rapidly and hospitalization became medically necessary. The family scrambled to find an inpatient treatment facility in the lower 48 because, of course, there isn't one here in Alaska that would take the client on short notice, so within a day or 2. And one of the parents accompanied the client, and has been with the client ever since through several transfers to higher level of care facilities down south. So, some factors that I believe are associated with a later diagnosis include the following. So the client's parents report that, he has always had a very rigid, polarized cognitive style and a tendency to hyper-focus on very special interests. They also report that since early childhood, he's struggled with social connections. He's been withdrawn compared to the other sibling. And they report that during the initial stages of the disordered eating process, they believed that, these signs and symptoms we now recognize as here's an evolving eating disorder, they appeared really congruent with his baseline functioning. And providers have since reported to the parents that they also had that perspective early on. It's also likely that because the client's gender and ethnic identities were incongruent with, existing stereotypes and misconceptions about who is susceptible to developing eating disorders that previous clinicians might have overlooked the early warning signs, right? How we conceptualize the client with an eating disorder remains really narrow in focus and doesn't accurately capture the true prevalence among, non-white and male populations especially. So as the client became more symptomatic, so we had really evident nutritional problems and psychosocial impairments, the parents became, a lot more concerned that something was very, very wrong. And they became more scared, and they more vigorously sought out medical and mental health treatment. They report they ran into a lot of roadblocks in their efforts to access care. They struggled to find providers who had competencies in this area. They felt that they were often minimized, their concerns were minimized, and they were repeatedly referred outside their home communities and their geographic region when providers recognized that they lacked the clinical competencies necessary. And these referrals were clinically and ethically appropriate, right? But each time this happened, the parents felt more isolated, more desperate, and the client became more symptomatic. So as rural Alaska is really under-resourced in terms of access to care, just in general, and specifically for eating disorders, this is a common experience I hear often from clients and their families. And the client's eating disorder began to evolve rapidly during the COVID shutdown years. With decreased access to medical resources and increased family and community stress and disconnection. So the family has now been separated for many months, with one parent remaining with the client down south, the other remaining with the sibling in Alaska. And over the course of this time, the family system has become increasingly strained and disconnected. The parent who has been most consistently present with the client through all the transfers has developed an acute stress disorder. The younger sibling back home in Alaska has recently become symptomatic for an eating disorder. And the family is considering relocating out of Alaska to continue accessing care. They're continuing to struggle with continuity of care issues and the reluctance on the part of treatment teams to actually engage them in the treatment team as well. So they're feeling really isolated and disconnected from the care their child's receiving and the care that really they need to receive as well. They're also struggling with a broader issue more recently about how we treat active eating disorders with co-occurring mood disorders. So the client's been discharged several times from either eating disorder treatment programs due to escalating depression with SI, or from inpatient mental health programs once SI has become more manageable due to an active eating disorder. Each time the client is discharged, there's no continuity of care plan. The client's just handed back to their parents. Their parents say, I don't know what to do. I don't know how to keep my child safe. And now I'm feeling more panicky, more isolated in a community that's not even my own, separated from all my support networks. So, I put up some questions on the slide about, themes and questions that I think this case study might illustrate for us that we could think about, right? Who's recognized as having an eating disorder? Who's overlooked? How does bias come into play here? Who gets included in the treatment team? And what would it mean to really integrate medical, mental health, family, cultural, and social resources in treatment planning? And how does the lack of diagnostic and treatment resources in Alaska and other rural areas impact patients and their families? How does this contribute to processes of disconnection from a sense of self, right, that is rooted in place in the land itself? That's important. Rooted in family and rooted in community. To be uprooted suddenly, placed in inpatient care so you can stay alive is so disconnecting on so many levels. And then how can we work collaboratively in interdisciplinary teams to retain clients and their families and their home communities, or at the very least their home state, to provide true continuity of care that works with family circumstances and that draws on the resilience and the strengths within the family system. So those are the questions that come up for me when I think about this case.
Thank you, Melissa. Wow, that is amazing and so helpful to start us off in our Project Echoes with a case that really pertains to issues in Alaska. This is, and especially in rural communities in Alaska. And so there's a lot to summarize, but I'm going to just do my best, and please jump in if I'm not getting the heart of what you're talking about. So the case is concerning a non-white cisgender adolescent male from rural Alaska, and who exhibits anorexia nervosa, co-occurring depression. The primary areas of concern sound to be this late diagnosis of the eating disorder, that there are signs and symptoms early on, but because he didn't fit the stereotype, or, for large part, that he wasn't diagnosed, that when the diagnosis did come through, his case was acute. He needed to be admitted to an inpatient facility. The parents are desperate. The patient is more symptomatic. And basically there is a lot of high stress on the family and a sense of isolation, especially due to the lack of accurate and timely diagnosis. And not only is the eating disorder getting worse, the depression is getting worse as well. So the questions, and you do have, several questions. And so I'm trying to, I'm not sure if we can get through all of them because they're great questions. One of your questions about who is recognized as having an eating disorder and what might we overlook, due to bias, who gets included in the treatment team, and how can we actively engage families? What I think some of these questions are underlying these questions is also kind of a vision of where we need to go, as a state. How does the lack of access to resources and care in Alaska and other rural areas of the country impact health outcomes for the clients and their families? And how can we work collaboratively as interdisciplinary teams? And I'm wondering if you might, with that, is there one question we can pull out that you would like this group to grapple with a little bit?
Let's see. I see a question that popped up from Grace. Should I respond to that or respond to your question? How best to do this?
Maybe I can just respond to that. I did put Akita's website information for local resources. There's also an events tab, and on the events tab, there are several programs for family support. So there's two programs. One is through UCSD and the other is through Dr. Laura Hill. And I don't want to take away from your case discussion. So I'd like, folks can go to that website, and I'll put that up there again. So
these are great resources that my clients find very helpful. Maybe the first one, who is recognized as having an eating disorder? And I'm curious about other providers' experiences with recognition or lack of recognition, who is seen and who is seen, and who is not seen. And, how can we address that?
Great. And we can also get clarifying questions. If anybody wants to ask any clarifying questions of Melissa, please enter that in the chat. And otherwise, please unmute or ask questions about this. And I see that we have one already with Namisha. You're on mute.
Forget that. Just wanted to say thank you so much for doing this. I was just very curious, and practicing in a state like Texas, we have so many resources around us that we often don't think about rural areas such as the one that you're describing right now, and how limited the resources are right there. As far as recognizing kind of like the profile of somebody who has an eating disorder, I think it also starts from within the family culture as well, and the ethnic culture that they belong to, and their understanding of eating disorders, and their thoughts and views around food, weight, and eating. And then being in a rural area, that must as you mentioned before, it kind of just isolates them that much more. And I'm curious as to, I guess, the kind of education or the resources, or even resources for mental health and nutrition professionals to be educated about eating disorders, and integrating that education with the ethnic culture there.
I think that cultural congruence is really key. You know, we see that a lot in Alaska. This is a really salient issue for us here. And I know for, at least from my experience, most families aren't expecting this, right? It just hits them as a shock. And especially when other providers are not picking up on it. And so I think that, you know, like the efforts that Akita's doing and that everyone's doing here to start working with providers one-on-one and agencies to really start developing recognition of eating disorders, the signs and the symptoms. We're, you know, not asking people to be experts by any means, but to recognize when a referral would be helpful, to be able to administer some basic standardized, perhaps assessment measures at the primary care provider level, maybe. But then also, as the parents of this client pointed out to me, even within schools, right? And even within schools, some education there as well. Mom said, no one noticed. Nobody did.
Right.
And we felt like failures.
Right.
Right.
I want to mention there's something in the chat somebody included, and also I do know that we were running just a bit behind tonight. So as we're talking about feedback, if folks have some suggestions or recommendations that can also be shared, that's very helpful. And Julie Mosley had asked about, I wonder how often we overlook eating disorders due to a co-occurring mental illness or substance abuse disorder, that is more easily noticed.
Yep.
And, you know, I don't know if that was the case in this situation, the depression or other kinds of things, but you're aware of eating disorders, and it seems that that was the eating disorder was not as well noticed, but I don't know if that was a factor that could play into this.
I think that's excellent, right? Add that to the list of all these other presentations and demographic stats, and that maybe eclipse an eating disorder. You know, a substance use disorder might be more evident. You know, for this kiddo, I really think that the neurodevelopmental condition, or at least, you know, likely condition, eclipsed it for a long time. And sort of also the parents didn't know what to do with that either. For many, many years, they did not know what to do with the neurodevelopmental condition. They didn't know, because that's also another under-resourced area of the state. And so they just sort of become this resigned. This is my kid. This is my kid. I don't really understand my kid, but this is who he is. And then it started to evolve, you know, into an eating disorder as well. And they didn't quite notice it. And neither did providers either. In small rural communities, I think this often happens, that families and providers, they develop this sort of unified conceptualization of a person. And it becomes a shared understanding of who this person is. And it can be very difficult to expand that, if that makes any sense. Because small communities, they're like extensions of family. And so it's not uncommon to, and I hate to use this word, but I'm going to use it, to even collude, right? I don't mean that in a blaming way, but to participate in this more narrow understanding of who a person is.
I wanted just to share that there were some interesting comments, and Gail Marvin reminds us, and this is for everybody to really be aware of, that in many areas there may be a wait and see approach, but with eating disorders, there isn't time for that. As you mentioned, this acuity, you know, when the individual is sent out. And we do have some other, you know, comments about this, and I'm wondering if there might be recommendations about resources for being able to identify or notice eating disorders in rural communities. And I know that we have Lisa Alexia talked about continuing education sessions at the annual Community Health Aid Practitioner Forum. Akita has put a proposal in for that, so hopefully we can do that as well. But if anyone has, hopefully will be approved to present, but if anyone has any comments or suggestions about ways to increase this knowledge of awareness in rural communities, where it's often overlooked in urban communities as well, I should say, but with people who don't fit the stereotype. But I'm curious if people, especially in smaller communities, want to address that or offer any suggestions. And folks on the hub team can also jump in.
This is Crystal Claire again. I think one way is, through education, and, I guess I'm thinking more through a provider's lens, but I think if we could improve general education about how to talk to adolescents and how to go through a social history and how important it is to include eating behaviors and screening for eating disorders in every patient visit, and just to really normalize how important screening for eating disorders is, then it would really help in early detection, which would then help in preventing some of these more acute medical complications and these patient presentations that require even higher levels of care. So, I think from kind of a broader view of things, improving medical education on a whole, so that we're just normalizing screening for these eating concerns from the get-go for every patient, every time we see them. I think that also helps with having this kind of unified conceptualization of our patients. If we're asking every time, we're not going to miss it, and we're not just going to kind of bundle them up into this archetype of who we think they are.
I think rural practice providers are amazing. I mean, they do everything. They do everything, and I wonder if there is a way we can make this easier and more accessible to them, because already there's so much on their plates and no one can be expected to catch everything. That's just impossible. So being able to do this from this place of openness without any judgment whatsoever.
I think what we're seeing is a lot of recommendations about just further medical education, like Dr. Cuellar mentioned, and also, just trainings and getting the word out as extensively as possible. I like the comment, Dr. Cuellar, that you mentioned about, just including screening questions for eating disorders in every intake, in every, conversation, that this is as important as anything else. It's and Jessica Setnick, who is with us, has said, if you're a provider, you are seeing people with eating issues. And so there are, screening questions in the chat. There was a screening one about someone introduced the EAT 26 to primary care providers in a rural Western Colorado clinic. They're excited to use that. So we do have, some good comments about this at Alaska School Nurses Conference. And I put my email in the chat, and I would welcome folks to get in touch with me. And then also we will share this feedback too with Melissa Marconi-Wenzel on the recommendations about how in Alaska and how in rural communities we can start increasing the knowledge, the ability, the awareness of folks to start realizing that eating disorders exist in all bodies, again, in all types of demographics. And how do we start screening for that? So we will take what is in the chat, and I believe we'll share that. Melissa will be able to share that with you. I And I think we are right on schedule that I need to turn this back now to Erin.
Yeah, we actually do have a few minutes. So I know there are a lot of great, comments and questions in the chat. If you want to take a few minutes, Beth, and just speak a few of those out loud, or if there are any final thoughts from our Hub team members before we close.
Yeah, and I guess I should ask you, when do I need to finish this then? So I'm keeping it on track for you.
Yeah. So just leave me a couple minutes at the end. So let's go ahead and take maybe 3 or 4 more minutes to cover some of these questions here.
Yeah, I think that there are so many good questions. A lot of this is, also changing the way we think about what is healthy, that we see thin bodies and think of thin bodies as healthy bodies. And that's the only, and people overlook when people are losing, weight, which is definitely not healthy in this situation. I would say that, Melissa O'Neill, I wanted just to read what you said about, part of it is relearning how we as providers think and speak about food and eating behaviors. And she mentions having spoken with countless families and providers who've gone to great lengths to rule out everything but the eating disorder, as if having an eating disorder was the worst possible case scenario. And part of the remedy must be that we as providers increase our multicultural competence and ability to speak about these issues without bias or judgment, so that this is it's a medical complication, it's a psychological complication. And so feeling some confidence in bringing this up and talking with others. And Jessica, you've got your hand up. Jessica sat next, so if you want to make a couple comments.
So you mentioned talking about questions to ask in an assessment, and I agree. I think any assessment from any professional can include a question or two about, just simply what's going on with your eating, and then why, what's changed. To me, it's always about what's changed. Let's say someone has always, chosen to eat gluten-free. I'll just make that up in my head. Then nothing's different. But if they've recently changed to eating gluten-free, that's significant. If someone's recently stopped drinking soda, that's significant. And we need to ask why, instead of projecting our own point of view on it. Like, well, why would you go gluten-free? I mean, you don't have celiac disease, so you don't need to eat gluten-free. So I'm putting my point of view on someone. Or, well, you stop drinking soda. That's fantastic. That's so healthy. Again, putting my point of view on someone instead of saying what changed for you, because the exact same behavior in 2 different people, for one, it could be a great healthy choice. And for the other person, it could be very dysfunctional and disordered. And so I think people get very scared about asking about eating because they don't know what they will do if they get a positive answer. And I saw in the chat, someone said they're almost reluctant to ask about an eating disorder because there's so few resources to refer someone to if they find out that someone does have an eating disorder. And I think that we want to take a different approach and say, I want to find every eating disorder among every one of my patients as early as humanly possible, because that's the best chance we have at getting things handled before someone needs to actually leave their home. And so not being afraid to ask what has changed about your eating and why. I think that's the simplest questions. And that's great that those providers are interested in the Eat 26, but I don't want anyone to be intimidated and think I need to ask 26 questions. Absolutely not. What's changed about your eating and why? And that can open a door.
Thank you, Jessica, for that. I think that's really helpful. And I'm going to, right before turning it over to Erin, just summarize also that we've heard from someone who lives in Nome, Alaska, which is rural. And he said that's very much the case, that the prevalence of eating disorders is extremely high. And it's because it's very much brushed under the rug because providers do not know how to handle or approach it. So I love that idea about let's find every eating disorder that's out there. Let's talk about it. Let's bring it out in the open. And now with 2 minutes to go, Erin, I will turn it back to you at this point. And thank you for all of these questions and comments. And I think it'll be really helpful to look at these after.
All right, thanks so much, Beth. And thanks so much to our participants for really great engagement during our session. Lots of fantastic questions that I know our team is highly interested in circling back to post-session. So we will do our best to gather those and either integrate them into upcoming sessions or get back to you with the resources, answers, or other support that you may need and be asking about. All right, a few reminders and items before we close out. If you would like to access continuing education credits for this series, you'll need to be utilizing the link that's in the chat that will take you to a survey to fill out. You will have an opportunity to complete that survey and receive your certificate up until the start of our next session in 2 weeks. So please take a look at that and fill that out so you can get the credits that you need. Let's see here. And a couple other things. So our next session will be in 2 weeks. Again, our series is bi-weekly, and it'll feature a presentation by Dr. Melissa O'Neill, who's also a member of our hub team and offered and is here with us today as well. And she'll be presenting on identifying eating disorders across the lifespan and the eating disorder screening and assessment tools for children, adolescents, and adults. And that will be on Wednesday, September 21st at 6 p.m. Alaska Standard Time. And we certainly hope to see you there. Again, please check out that survey link in the chat. Even if you're not receiving continuing education credits, we invite you to fill that out, as it is a great way for us to understand more about the impact of our session and what we might be needing to do to improve as well. Again, my thanks for your joining us today. It was a pleasure to have you for this first session, and we look forward to seeing you in a couple weeks and certainly over the course of the rest of our series. In the meantime, do your best to take care of yourself and each other, and we'll see you soon, folks. Hub team, if you wouldn't mind holding on for a few minutes, I'll go ahead and invite you to a breakout room where we can debrief. Thanks so much.